So this figure here is a really good figure to use to talk about recruitment of very premature babies. Now, the ideal way to do a recruitment manoeuvre is to use high frequency ventilation. So you start the baby on the high frequency ventilation you think will work, and often with recruitment manoeuvre the big problem is oxygenation. So this is a baby that your main problem is you're needing a lot of oxygenation. You look at the chest x-ray, the chest x-ray looks quite white, maybe low lung volume, suggesting that the lung has collapsed down. And so you think to yourself, probably the main issue with oxygenation is because you've got ventilation diffusion mismatch, because the lungs collapse down, you haven't got good levels of oxygen in the air sacs, so the pulmonary vessels are constricted. So the idea is with the high frequency ventilation is you use this dynamic compliance loop. So the way you do it is, so you start off on whatever ventilation you're on. You increase the mean airway pressure by 1 centimetre of water, and you wait 2 or 3 minutes. And often what you'll see is a little bit of an improvement in oxygenation. So you then do the same thing again, and you see a little bit more improvement in oxygenation. And basically, you keep doing this step by step at least every 2 minutes. You don't want to do it really quickly. You really do need to make a step and sit back and wait for 2 minutes, which is a long time when you're standing by the bedside. You keep doing that as long as the oxygenation keeps improving. Then what happens is you reach a point where you go up on the mean airway pressure and the oxygenation no longer gets any better, or sometimes even gets a little bit worse. At that point, what you know is you actually expanded the lung really well, but you're often on very high pressures. So I've taken a little baby on maybe a mean airway pressure of 12, and by the time I get to that point, the baby's on a mean airway pressure of 24 on the oscillator. Now that sounds really terrible and scary, but in doing that, what we've done is we've taken a baby who was maybe on 80–90% oxygen and not saturating well, and you've got them back down to about 40% oxygen, but you can't leave them on a mean airway pressure of 24. So what you do is you then start doing the reverse, and you go back on the mean airway pressure by 1, wait for 2 or 3 minutes. And you keep doing that as long as the oxygenation stays the same. You then reach a point where you go 1 step more and the oxygen requirement starts to go back up. What that tells you is you've gone from this part of the curve down to about here. So you're starting to lose lung volume. So what you do is you go back 1 step to where the oxygenation is good, and that's where you leave the mean airway pressure on the oscillator. And often, like with this little baby that I was talking about, so we got to a mean airway pressure 24, we were able to bring the baby back down to a mean airway pressure of 15 or 16, and the baby was still in 40% oxygen. Now, if I had just pushed the mean airway pressure from 16 up to 18 and just left it like that, the baby would not respond really well. That'd be a bit better, but I wouldn't get them down to 40%. So this stepwise recruitment manoeuvre is a very important step to use when you're having major problems with oxygenation in a chest x-ray that looks like the baby's de-recruited. And that will often be in a scenario like you've extubated the baby and the baby's failed. Their lungs are really collapsed down now. So you need to re-recruit the lungs. Just putting them back on the ventilator, often they'll still be in 80-90% oxygen, nothing's really working well. If you do a proper recruitment maneuver, you can rescue those lungs very quickly. The other time that might happen would be a tube blockage, or sometimes the tube moves down the right main stem bronchus and you lose all the volume on the left side. Repositioning the ET tube and then doing a recruitment maneuver can significantly improve that baby. But you can do it with conventional ventilation, but it's a lot more difficult. If I were going to do a recruitment maneuver, I would routinely just change the baby straight over to high frequency if I can do that. I understand you've got high frequency ventilators. The lungs. So as I mentioned before, in acute lung disease, the airways are normal. So gas moves in and out quickly and easily, and with just normal PEEP, the airways are splintered open. There are two sorts of problems where I think we can get auto-PEEP. One would be bronchiolitis. So I don't know what happens in your units, but in our units, when we have babies come in from home with bronchiolitis, if they're very young, sort of maybe 4 or 6 weeks, they get admitted to neonatal intensive care, not paediatric intensive care, because we know more about little babies. But the problem is we often think of them as being just like newborn babies with acute RDS. So we try to ventilate them with short inspiratory time, short expiratory time, and fast rates. Now the problem with bronchiolitis is the airways are swollen. So now you've got high resistance. So the gas flow in is slowed right down. And the gas flow back out is even slower. And what happens is as we sort of ventilate them more like a newborn, is each time we sort of ventilate them, we actually, instead of, see this point here is really important. So when you look at the curves on the ventilator, look at the pressure flow curve, what you see, pressure flow is you see as the lungs start to fill, the flow is high. As you get closer and closer to full inflation, the flow slows right down. And when you get to full inflation, you actually reach zero flow. Now and the same happens with expiration. Initially you get fast flow of gas, slows down, and when the lung is completely empty, there's no flow anymore, so you're back to zero. Now what happens if you've got a lung that's got high airways resistance and you use a short inspiratory time, you see the flow go like that, but it doesn't come back to zero. It just suddenly drops. When you see that type of flow wave when you ventilate it, it means your inspiratory time is too short. And so what you do is you gradually increase the inspiratory time until you see the ventilator curve come back to zero again. And it's the same with exhalation. What happens is during exhalation with high airways resistance, is you've got this very long tail. And it's not until you reach zero that the lungs empty. And so what happens is if your expiratory time's too short and your rate too high, is you clip it off there. And so it means that this volume of gas is just sitting in the lungs, going nowhere. And then with the next breath, you get that amount of gas staying again, and you tend to get very overinflated. And you look on your x-ray, and the baby looks really overinflated. And you think to yourself, if the baby's overinflated, the problem must be too much pressure. But it's not. It's because your ventilation is set up wrong. So first of all, one of the things you can do is you increase your inspiratory time, you increase your expiratory time, and then you slow the rate down, really right down. And that will help with the auto-PEEP. The other problem you can get is, particularly in babies who've been on the ventilator for a while, is they get bronchomalacia. So these airways, they become very floppy. It's something we recognise in babies with chronic lung disease that have been on the ventilator for a long time. So what tends to happen is particularly during exhalation, as the gas flow goes out, it tends to collapse down these floppy airways. So even with an increased expiratory time and a slow rate, you still get collapse of some of the airways and you get gas trapping. Now you'll sometimes see this in a baby, and maybe it will just be on their chest x-ray, one section of their lung is really overinflated and gas trapped. That could be because of bronchomalacia. You've got an overdistended lung, and you think the worst thing you can do is actually put the PEEP up. But in fact, the correct way to manage this is you put the PEEP up, which holds the airway open during exhalation, so that you can now get gas flow out. And there is a way you can look at on your ventilator to see if that's happening. And I'll have to look at the ventilator, but basically what you're doing is you're sort of looking at volume flow loops. And so volume flow loops kind of look like this, a big circle. And the important part about the volume flow loop is if your lungs are behaving normally, this can sort of be a bit wiggly and a bit strange shaped. But what you need to see is that at the end of exhalation, it's come back to the same point. If you've got bronchomalacia or airway collapse is your primary problem, what happens is you see this. So long before the lung is completely emptied, you lose flow because the airway collapses. And that's the hint that you've got bronchomalacia or airways collapse. And what you do is you increase the PEEP bit by bit until you correct that. And often what you'll find is that by increasing the PEEP and splinting those airways open, that the lung starts to deflate, even though you're on a higher PEEP. And gas exchange is better, oxygenation is better. So we don't generally see this in acute RDS, very unusual. Occasionally we see it in babies who've got like congenital bronchomalacia, but this is certainly a recognised problem, and it's typically the very little baby who's been on and off the ventilator over a period of many weeks, and their lung disease is just getting worse, and they start to get gas trapping and auto. So that can be an explanation for it. I'm just trying to think in terms of acute RDS, do we ever see auto PEEP? Again, the only time I can think of auto PEEP in acute RDS is sometimes if you try to use higher rates. So I generally don't go over a rate of 60. The problem with conventional mechanical ventilation is as you start to push the rates up, so you're having CO2 problems, you think maybe I'll fix it by going to a rate of 70, rate of 75, is the ventilator, mechanical ventilators, conventional ventilators become mechanically inefficient at that time, and you get into problems where you can't achieve full emptying of the lung in the very short expiratory times you need with when you're trying to use higher rates. So generally I wouldn't go over a rate of 60. I mean, that's when we look at why do we use high frequency. One of the main reasons why we use high frequency in very prone babies is high frequency is much better at exchanging CO2 than a conventional ventilator. So one of the reasons why I would use high frequency in a preterm baby would because with my conventional strategy I'm still struggling to get the CO2 down without using really big tidal volumes or really big pressures. I know if I switch to high frequency, the CO2 exchange will be much better. And one of the things you have to be careful of when you swap a baby from conventional ventilation to high frequency is sometimes the CO2 can drop really, really quickly. And you don't want that because the premature baby's brain circulation is very CO2 sensitive, and if you have very low CO2s for longish periods of time, you actually restrict blood flow to the brain. Now we saw that in the 1990s when we didn't know this, and we didn't worry too much about low CO2s, and what we were seeing was babies surviving with periventricular leukomalacia, and it was found that that was related to low CO2s. So I'm always really careful when I swap from conventional ventilation to high frequency ventilation in monitoring the CO2 to make sure it's not going like that and ending up at 20 or 15 when I do my next blood gas.